Dr. Murad?
Yes, doctor, I'm with you.
Yes, okay. Would you proceed to ask the questions?
Okay, doctor. Okay. Okay. So I try to open the chat, but I'm
Yes,
face
I
now.
opened it from my computer.
Okay, I face some problems now. So
From Q&A, Dr. Asula.
yes.
Can I do the job
So
instead of you if you have a technical problem?
okay.
Okay,
Yes, please, doctor.
Dr. Noel Asmar. How are you, Dr. Noel? Very good friend from Lebanon, Beirut, Lebanon. I wish that everything will be okay in Beirut, Lebanon, inshallah. She is asking about aspirin is safe even when doing FNA for cystic lesion. Is aspirin safe even when doing FNA for cystic lesion? Dr. Ahmed Murad?
Yeah, we consider FNA from a cystic lesion is a high risk procedure, but the aspirin is safe, but you must do CBC and INR before the procedure. But as aspirin, you just continue aspirin as it is, no problem at all, inshallah.
Okay. Another question from Dr. Mahasin Shair, very good friend of us. She is asking whether water and not air. I think it should be water. Air is the enemy. Air is the enemy of endoscopic ultrasound. Air is only important when you are on the endoscopic view to go with the echo endoscope to the stomach and then the duodenum. And then after starting the sonographic view, then you should suck continuously the air from the anatomical part you are in.
What is the question, Dr. Hussein?
I don't know, but it is written water, not air. Yes.
Yes, sure. Air just to get the way. And after you reach the antrum, you suck air from the stomach and you just inflate air in the bulb of the duodenum to be sure that you are in the right way. Because as I said, the bulb of the duodenum is considered a dangerous area. You must do the manipulation under vision, and to go to the second part of duodenum if you want, you must be under vision and you need air here. After that, you suck air continuously. You not need air after that. Water is okay in the bulb for a minimum amount of water, minimal amount of water from 50 to 100 cc just to opposing the papilla. And after that, no water, no air. Just become nearby the wall by manipulating the knobs of the scope.
Okay, a question from my dear colleague, one of my best colleagues, and who will give a lecture later on in the, I think in the third day, Dr. Khalid Ragab from Theodore
He asked about tissue harmonic.
Yes, asked about tissue harmonic. I think Dr. Amr Abul Magd can answer this question.
Yes.
Of course, tissue harmony is very accurate before we can deal with the machine of sonar. The machine can easily go some sort of tissue harmony and enhancing of the lesion accuracy. I can use the machine for proper instruction or some physics. I will just know about some physics of the machine. The tissue harmony can easily identify or increase the tissue accurate or visualization in proper way.
Okay, a question from Dr. Abdelmajid Mahmoud, role of endoscopic ultrasound in treatment of bleeding gastric varices. Actually, in Egypt is a very nice question. Thank you. Actually, in Egypt, we are used over tens of years to deal with bleeding gastric varices due to the high prevalence of hepatitis C virus cirrhosis in Egypt over the last 50 or 60 years, and also bilharziasis. Now, thanks God, the situation is much more better after the introduction of the new drugs, but we'll have a big deal of experience with the gastric varices. We are used to inject histoacryl or cyanoacrylate according to the recommendation of our mentor and Professor Mazen Naga. After the introduction of endoscopic ultrasound, we can inject it in bleeding gastric varices, especially when the field is covered with excess blood. But actually, here's the advantages of endoscopic ultrasound. It depends on the sonographic picture and not the endoscopic picture. So it is an advantage over the usual upper endoscope that excessive bleeding cannot hide the varix, because the bleeding varix is seen by sonographic view and not by endoscopic view. But actually, if if you position the patient in the prone position, the patient lies on his face, the blood will trickle on the dependent area away from the fundal varix. So we can visualize the fundal varix very nicely. If the patient was put in the prone position and with some washing or some water wash, we can see the fundal varix very nicely. So I think the EUS has not do not have that great advantages over the upper endoscope.
Dr. Hussein?
I think endoscopic ultrasound injection of gastric varices, whether by histoacryl or coiling, here the advantage of putting coils by the 19G needle, advantages of endoscopic ultrasound put a coil, but here we are used to do and perfecting the injection of histoacryl due to the large number of cases. So we are not doing EUS coiling of gastric varices because it is very, very, very expensive, much more expensive than histoacryl. But I know that in many countries, which can deal with the high cost with the coils, are doing coiling and histoacryl, because introduction of coils will minimize or decrease the amount of histoacryl, so minimizing its complication as embolization in distant organs.
Dr.
But here
Hussein,
in Egypt, the cost effectiveness, the coils are very costly, so are using histoacryl always, but we can use it if you have insurance and you can provide we can cover the cost of the coils. We can do the best is combination of coils and histoacryl.
Dr. Hussein,
Yes.
you know the shared case of recurrent gastric varices bleeding. We did endoscopic ultrasound. We discovered that there is no submucosal vein, and we have only a large perforator. And this patient is referred for surgery rather than a trial of recurrent of injection. So
Yes,
we recommend if there is recurrent injection with unsuccessfully of proper hemostasis, we can do endoscopic ultrasound for proper re-evaluation and change decision, either go surgery or TIPS or giving another modality of treatment.
Yes, a very important point I forget to mention, but this point is very, very, very important. In Cairo University, we are working with a very important aspect is recurrent bleeding after histoacryl injection. In patients with fundal varices, about 3 to 5% of patients injected by histoacryl, 3 to 5% of fundal varices injected by histoacryl had recurrent bleeding. These patients are very important to do endoscopic ultrasound. During endoscopic ultrasound, you find either one of two. You will find a hidden submucosal gastric varix, just bulging a little bit on the fundus of the stomach, so not seen by upper endoscopy, and it's largest part is hidden. So this is a very nice finding and can injected by either upper endoscopy or by endoscopic ultrasound. So sometimes only minimal part of the gastric varix in the submucosa are seen in the fundus, and most of its part is bulging extramurally. So this is the tip of the iceberg. So it is very nice finding. And sometimes we didn't find, as you said, any gastric varices, and see only perforators and peri and para gastric and peri and para esophageal collaterals. These cannot be injected by endoscopic ultrasound, because in endoscopic ultrasound you just inject and coil gastric varices, not perforators and not perivascular or paravascular collaterals, and these patients should be referred for surgery. I remember I reached 7 cases with recurrent bleeding after histoacryl injection, recurrent bleeding after histoacryl injection of gastric varices, out of hundreds of cases. And in these cases is referred for endoscopic ultrasound, especially by my dear Professor Mazen Naga. And in these 7 cases, we find hidden gastric varix in the mucosa, and you can inject it by histoacryl during EUS, or pointing to my professor or by me that the varix is located here. This very small elevation is a varix, and sometimes the varix can be mistaken for an exaggerated fold, so we can differentiate and then inject it by histoacryl and stop recurrence of bleeding. So thank you for this very important point. Another question. Beautiful presentation, Dr. Akasha. Recording, okay, excellent teacher. As an inch, I find it difficult. Yes, from Dr. Shafkat or Shaukat Rasul. I find it difficult to trace common bile duct in the duodenal bulb towards the papilla and liver hilum. Tics and suggestions. Yes, it's a very important question. You want to trace the common bile duct while in the duodenal cap or the duodenal bulb. When you are at the duodenal bulb, you can locate your landmark, which is the confluence of the splenic superior mesenteric and to form the portal vein. You can do clockwise rotation, very gradual and very slow. Clockwise rotation, very gradual and very slow. Clockwise rotation, you can locate the common bile duct and the pancreatic duct while going to the papilla. But you are asking towards the liver hilum. When you want to trace the common bile duct towards the papilla, you should do clockwise rotation. Clockwise rotation after you locate the confluence. So you locate the confluence and do clockwise rotation. You can see the confluence of the common bile duct and the pancreatic duct into the papilla. But if you want to trace it to the liver hilum, it is somewhat difficult. But you can obtain it by locating the duodenal, the echoendoscope in the bulb, and starting to do anti-clockwise rotation. By anti-clockwise rotation, you can trace the common bile duct, its proximal part, to the cystic duct and the gallbladder, which can be located, as I said, in the most anti-clockwise position. So when you'd like to trace the distal part of the common bile duct to the papilla, you can do clockwise rotation from the venous confluence, and if you want to trace the common bile duct to the gallbladder, you can do anti-clockwise. It is difficult and needs much more training. You can do it in every patient, but in a very slow and careful way in order to avoid complications. But you are right, this is very difficult, really, sometimes very difficult to trace. It may be much more easy in case of CBD dilatation. In case of CBD dilatation, you can locate the venous confluence and do anti-clockwise rotation. You can do the confluence, and in front of it is the common bile duct. You can do very slow and careful anti-clockwise rotation. till you trace the common bile duct to the cystic duct and the gallbladder. But actually, it is a very difficult task and needs training. But when you try in more and more patients, you can do it, and you can start by the patients with obstructive jaundice, with dilated common bile duct. It will be much more easy. Yes, good evening, sir. Did you ever face hydatid cysts of the liver or pancreas, and what are their features to avoid puncturing them? Yes, a very nice question. I uploaded a very nice case of hydatid cyst diagnosed by CT as a pancreatic cyst, and during AUSC examination, it was found that it is a hepatic cyst and not a pancreatic cyst, because the cyst moves over the pancreas. The liver cyst, the liver moves with deep inspiration, with inspiration during anesthesia. The liver moves up and down, and the cyst inside the liver sliding over the pancreas. So it was not a pancreatic cyst, and it was a hepatic cyst. So I face in my life over the 22 years, only one case during AUS examination of hepatic hydatid cyst. And the feature is you should go to the WHO classification of hydatid cyst and the 5 stages. Very nice. You can go to it. I gave a very nice lecture during the sonographic course of different shapes of the morphology during US and during sonography of the hydatid cyst. You can contact me on my WhatsApp number or my during Messenger, and I can propagate the lecture for you. The WH classification of hydatid cyst, stage 1, 2, 3, 4, and 5, with water lily sign and cogwheel sign and so on. So you can contact me on the WhatsApp or the Messenger, and I will upload the lecture for you. And thank you for this nice question. Another, yes, please upload these videos. Amazing, excellent presentation. So I think
from Argentina, we sent congratulations from Egypt to Argentina, Dr. Hussein.
Yes, thank you very much for all our colleagues of the Facebook group AUS Club Egypt. Thank you very much for your interest and your enthusiasm in AUS learning. Just here 2 questions. Thank you, Professor. With you, studying special anatomy, and most of the pictures. What is the role of balloon, please?
Yeah,
I think Dr. Ahmed Murad answered.
Balloon at the beginning of AUS, in the beginning of AUS training, they emphasize the role of balloon. But now the role of balloon, sometimes during introduction, it may be facilitate introduction from the beginning of the entrance of the scope in the throat. And the introduction also, it stabilizes the endoscope in the part of the duodenum. But the balloon role is not like that. The balloon at the beginning, its role that it creates a media of water surrounding the probe to enhance the picture. But it carries the disadvantage of this water contain air bubbles. So you must suck the water and inflate and give water again inside a balloon. And most of the endosonographer now not use a balloon as a guide or as to help them in a good picture. So I think the role is not so important now, but it's present. If you prefer it, it's okay, but use it probably that you suck air at the beginning, and after that check before introduction that no air inside the balloon, and then try to fill it with water to examine it before introduction.
Okay, another question from Dr. Mahasin Al-Sha'ir. How much is the percentage of metastatic liver tumor? In our study, 750 patients with pancreatic, GI, and lung malignancy. The percentage 6%, 6, not 16, not 60, 6%. 6% of cases, about 17 case out of 750 proved to have liver metastasis not seen by CT or MRI. Another question from Dr. Shaukat Rasool. Once found portal vein in the duodenal cap, what will movement to find the CBD? Another nice question. As I mentioned, when you find the portal vein, you can do very gentle anti-clockwise, very gentle clockwise, very, very gentle and very slow. You will find it immediately, just at the level of the venous conference, or with minimal anti-clockwise or minimal clockwise. But my advice here and my tip here is do somewhat downward deflection. Push the big wheel away from your body. Do downward deflection, very slow downward deflection. It will release the common bile duct because sometimes you are compressing it by the echo endoscope. So release the down, so some the downward movement by pushing the big wheel away from your body. Another very important question really about the pancreatic divism. Very, very important question really, but it is very difficult to answer it without showing the videos. So I will prepare a very nice video with Utopia company about pancreatic divism. So I will promise to do that because it is a very difficult task. You cannot answer it without nice videos, without nice demonstrating videos. Dr. Wael Haj Majid.
Yes, Dr.
How are you,
Hussein.
Dr. Wael?
Yeah.
From our dear colleagues from Sudan, I think. We love Sudan very much, and we love our colleagues from our lovely country, neighboring country, Sudan. Is EOS superior to CT scan in the diagnosis of gastric ulcer? Would you like to answer, Dr. Murad?
Yes, yes. Generally, we don't prefer to compare EOS with CT because it is not a competitor. It is just a primary examination and secondary examination. They help each other in about all cases. CT, no EOS without CT, generally. So CT is the basic. You screen, you saw, but here in this gastric cancer, for metastasis, you must do CT. EOS is better in evaluation, especially in early gastric cancer, the extension, the staging, the lymph node, surrounding lymph node. But CT, you must do CT or PET scan to evaluate what is the extent beyond the scanning of the EOS, the mass reaching the liver, the mass reaching the lung or something like that. So we don't prefer this type of comparison because they usually and they always, as I said, always helping each other. They are a team, not a competitor.
It can be
Yes, a very nice question from Dr. Mirad Odobazic from Sarajevo. From Sarajevo, Bosnia and Herzegovina, Bosnia and Herzegovina. We are welcoming you very much, Dr. Mirad. He is asking a very nice question. Is the cancer stenosis of the lumen? I think if the cancer stenosis of the lumen of the esophagus over 80 to 90% of the lumen, contraindication of endoscopic ultrasound. And is there some algorithm when you can't go through the lumen because of the fear of perforation? Thank you very much once more for such a great presentation. A very nice question, and I can answer this question.
Yeah, but there is a lecture about that after next week.
Yes, there will be a lecture with Dr. Ahmed Murad, I think in the next Friday, I think. Yes, but I can here give some hint because we did a lot of cases of sampling esophageal tumors in case of esophageal stenosis. When there is esophageal stenosis, the outer diameter of your linear echo endoscope is about 14 millimeter. So in many instances of cancer esophagus, there is marked stenosing preventing further progression of the echo endoscope. So here I can do my job. I can impact, I can pushing gently the echo endoscope in the upper aspect of the stenotic area. And then the echo endoscope, the field of the sonographic view is a sector. It's not a rectangle or not it's not a square or a rectangle. It is a sector. So it can see about 3 to 4 centimeters below its tip. When the echo endoscope can sonographically see the tissue about 4 centimeters below its tip. So I can see 4 centimeters of the tumor when I locate the echo endoscope at its upper end. So I locate the echo endoscope in the upper end, and I can send my needle in the wall to take a biopsy, and very nicely seen because I can see the field for 4 to 5 centimeters. So it will not stop me from obtaining biopsies, because sometimes these tumors are negative during upper endoscopy, because it may locate it deeply in the submucosa, and repeatedly upper endoscopy is negative.
But
So I can do FNA only by locating at its upper end. But if it is a well-known tumor and the tumor was diagnosed and I am doing for staging, I can't do it perfectly, because I should go through the whole length of the tumor and go even below the tumor to see the lymph nodes and even to the celiac axis to the lymph node, and to see the lymph node in the celiac trunk. In the past, 15 years ago, I worked with echo endoscope from Olympus. I think it was NIH 908. It is like the cardiology. It is like the cardiology, the transthoracic echo. I put the upper endoscope and I put the Savary, the wire, the metal wire of the Savary dilator, and then we can introduce the EOS NIH 908 through the Savary wire. It has a sonographic view but no endoscopic view, like transesophageal echo exactly, and it is very thin, and it can go through the stenotic area and it can do it. But I think this type is obsolete now, is not there. I worked with it for many years, 10 or 15 years ago. About the issue, if you do dilatation, then introduce the echo endoscope, I don't recommend this at all, because this may lead to, it has a high incidence of perforation. So I recommend doing, if you want to go through the stenotic area, you can do dilatation in a session, and after a few days you can do the endoscopic ultrasound. Because if you do it in the same session, to introduce a very big echo endoscope, hard echo endoscope with 14 millimeter outer diameter through just or recently just dilated stenotic stricture, I think it carries a high incidence of perforation. And I saw myself one of my colleagues who did this dilatation and then introduced endoscope and followed by perforation. So I don't recommend that. I think Dr. Ahmed Murad wants to comment.
دلوقتي تؤمر بحاجة؟ أنا قلت أنت أكيد عايز حاجة في الميتنج. طيب أنا أكلمك مع السلامة.
حسين.
Okay. Now, uncinate process, the last question from my dear colleague and my dear brother, Mahmoud Al-Ansari. This is the last question, uncinate process versus ventral aspect of the pancreas, how to differentiate. I'd like to answer this question.
محمود يا دكتور حسين.
Yes, what?
هجاوب أنا عن دكتور محمود.
Yes, please. But speak in English, please.
Actually, uncinate process of the pancreas is the area just below the papillary lesion. So, if we are target the uncinate process, there is the area of below papilla. And it's very difficult to distinguish chronic pancreatitis in this area of answered process and ventral pancreas. So we do not recommend to get a final diagnosis of chronic pancreatitis in this ventral and answered process area. But the most important to distinguish the answered process, it is just the area below papillary lesion.
In station 1, as I mentioned.
Yes, that's right, sir. That's right.
Station 1, just below the papilla
Just
and
below
upward
papilla.
deflection. Then you can see the abdominal aorta as a longitudinal structure. Then the pancreatic tissue in this area is the uncinate process. I think Dr. Mahmoud Al-Ansari, I know what he's mean by his question. He wants, I think, to know whether the uncinate process is a part of the ventral pancreas or part of the dorsal pancreas. Uncinate process is a part of the ventral pancreas. It is
Yes.
hypoechoic, black, hypoechoic, black, ventral pancreas. This is the uncinate process. I think that's what is meant by his question. Do you agree with me, Dr. Amr, that it is the uncinate process is a part of the ventral pancreas and it is hypoechoic, and sometimes you can see it very differentiated from the dorsal pancreas, which is
Yes.
hyperechoic.
Yes.
Okay.
It's a part of the posterior head of the pancreas, ventral part and answered process.
Yes.
And he dance, and during dancing he rotates around the duodenum to be with the main pancreas underneath of it, forming the uncinate process.
I think now we are coming. There is a last question from Dr. Wael Ishal. Welcome, my dear colleague. Hello, thanks a lot for the nice lecture. I have a question. Is endoscopic ultrasound better than contrast metal abdominal ultrasound? Maybe contrast enhancing abdominal ultrasound to differentiate between malignant liver lesion,
Dr. Hussein, I think he asking about the differentiation between contrast enhanced ultrasound and EUS, and differentiation between malignant liver lesions.
لا, endoscopic ultrasound is finally an abdominal ultrasound. It is a sonographic view, but it is very near to the liver. Some areas are very near to the endoscopic ultrasound, but finally it is a sonographic. I can suspect malignant lesion by endoscopic ultrasound, as we see in the liver metastasis in my video, but I can't swear exactly like abdominal ultrasound. If you use contrast abdominal ultrasound, this is a contrast technique. It's a very nice technique, but not licensed yet in Egypt, not used in Egypt. But it is a very nice, and you can use also contrast during endoscopic ultrasound. When are doing contrast endoscopic ultrasound, you can use contrast even in cystic pancreatic tumors, as Dr. Ahmed Murad said. So endoscopic ultrasound is equal to ultrasound because both are ultrasound, and we can do contrast ultrasound in contrast enhanced technique in abdominal percutaneous ultrasound and also in endoscopic ultrasound. But I think that the main and the principal and the most important value of endoscopic ultrasound is to do FNA, because we can't give chemotherapy based on contrast enhanced ultrasound. We can't give chemotherapy based on elastography, but we can do it by tissue diagnosis, because it may be a metastasis, it may be HCC, it may be cholangiocarcinoma, and each tumor has a different protocol during chemotherapy. So I think that the main advantage of endoscopic ultrasound is to do FNA when you have a suspected lesion in the liver during scanning or during the workup of pancreatic, lung, or GI malignancy. I think here, because endoscopic ultrasound can target some segments very easily, easier and more safe than the abdominal ultrasound.
I think, Dr.
This is the
Hussein,
last question. And many questions asking about the active link of recording. The day is recorded, and the link will be available soon, as promised by Utopia Pharmaceutical Company, maybe on next Sunday after 2 to 3 days. And they asking about the credit hours. This course will have nine credit hours. A very nice achievement.
Dr. Hussein, from here we sent congratulations and thanks to Dr. Ahmed Al-Ghubari, who do a lot of effort to create this credit hours and give it to this course. And
yes.
To him, thank you, Dr. Ahmed Al-Ghubari.
And these credit hours will be given to all our colleagues, our attendees, after the fourth day of our basic course. Finally, I am very happy today, and I have a pleasure and honor to meet you, my dear colleagues, about 200 participants today. 200 participants. Thank you very much for your interest in endoscopic ultrasound. Thank you very much for your patience. Thank you very much for your enthusiasm in EOS learning. And this is the first thing which I should say. Thank you very much again and again, and thanks for our dear colleagues, Dr. Professor Ahmed Murad, Dr. Ahmed Zamzami, Dr. Amr Abul Majd. Thank you for Utopia Pharmaceutical Company for the very good arrangement, Dr. Siola and Mr. Ahmed Magdi for the technical support. And looking forward for the second day of our course, which will be the next Friday, 16 October, in the same time, 7:30 p.m. Thank you again, and see you next week, inshallah.